Thank you. The title of my talk is No Rhino in Rhino Orbital Cerebral Mucormycosis, Atypical Cases, a Case Series. These are our financial disclosures, none of which are relevant to this presentation. We know post-COVID, mucormycosis has seen a surge that can present in multiple ways like mild, severe ptosis, orbital infarction, black S-char giving it the name black fungus, orbital infarction, and even severe proptosis causing globe rupture. Traditionally, what we know is that mucormycosis involves the nasal mucosa first, spreads into the paranasal sinuses, directly from the medial to the lateral edge spreads into the orbit, gradually creeps apically and posteriorly from the apex of the orbit and the cribriform fossa into the brain. Based on this understanding of ours, there has been a proposed staging of rhino-orbitocerebral mucormycosis, where in a stage-wise pattern, the involvement of the nasal mucosa is first stage. Second stage is paranasal sinuses, from where it spreads into the medial orbit, the nasolacrimal duct into the orbit, affects two structures, and finally to the apex, and involves the CNS and the central nervous system, the cavernous sinus and the central nervous system. There have been other studies as well, again using the same principle of a graded system. So we know that it is a stepladder progression with anatomical compartments that get affected one by one. Signs and symptoms help us to localize the lesion and plan the treatment with endoscopy and imaging in all these cases. The authors of this paper have written over 8 papers on mucormycosis with the largest series of follow-up of over 6 months. In our series, we've noticed that there have been some atypical cases, which is what we aim to present today, which is non-conformant to known disease progression patterns. In a single center with 88 patients with a minimum follow-up of 3 months, we had 57 cases, of which 6, which is 11% of the cases, had normal nasal endoscopic findings in mucormycosis. There was no S-char, necrosis or ulceration. However, 2 had orbital disease, limited, 2 had extensive orbital disease, 2 had apical orbital disease, for which in all 3 underwent orbital exenteration. At last follow-up, life salvage was 100%. Let us take a few index cases. This is a 65-year-old male with dull pain over the cheek for 5 days with absolutely no other visual complaints, recovered from COVID. An ENT consult was taken, a nasal swab was done, and this is the endoscopic video. Pristine, clear, healthy nasal mucosa with not a sign of even mild congestion. MRI, the maxillary and the ethmoidal sinuses are completely full. The pterygopalatine fossa lights up and mucosal edema is observed there. Endoscopic debridement was done, which confirmed the diagnosis of mucormycosis. For the limited orbital involvement, retrobulbar amphotericin B injections were given. Systemic treatment was done for mucormycosis, and at 3 weeks there was no recurrence. Patient was discharged on oral posaconazole after systemic ampho injection. Second case is a 53-year-old male, again with a history of COVID 15 days ago. Rapid onset of loss of vision, ptosis and pain. Again, nasal mucosa. This is an iatrogenic bleed caused by the endoscope. No ulceration, no S-char. However, the disease shows complete orbital involvement with loss of contrast and perineuritis. The sinuses are full. Again, you can see the contrast enhancement being taken up in the nasal mucosa, suggesting that the mucosa was still healthy. An exenteration was done and the patient was discharged after complete recovery. This is case 3, a patient with mild ptosis and nothing else, apical disease involving the cavernous sinus but pristine nasal mucosa. Which then brings us to this proposed staging that was seen. First case has no nasal mucosal involvement, so has skipped stage 1 and directly jumped to stage 3 without nasolacrimal duct involvement. Case 2 has no stage 1 involvement, has one sinus of stage 2, which is stage 2A to B, and directly jumps to stage 3B, not in a sequential form. This is the third case where again the nasal mucosa was normal, with direct jump from stage 2A to stage 3C and to stage 4A. So, coming back to this slide that we saw earlier, our series shows that this stepladder progression is no longer applicable. Anatomical compartments affected one by one is not the case. Signs and symptoms cannot help us localize the lesion. It is endoscopy and imaging alone that will help us decide. But why do we see these lesions that don't affect the nose and involve the sinuses. The important area that we forget is the infratemporal and the pterygopalatine fossas, which have direct access to the skull base, the orbit, and the apex of the orbit. Perineural invasion is the other mechanism that we tend to overlook. In addition, we are talking about severely decreased host immunity along with compromised local mucosal immunity, which allows the organism to invade. 5 out of 6 patients had edema and enhancement around the pterygopalatine fossa, which is a high risk of cavernous involvement. We have proposed a radiological based classification which has been published in Orbit. To summarize, stepwise progression is not routinely seen in mucormycosis. Aggressive disease, especially in rapid progressive form, is seen following COVID. Anatomical assumptions no longer hold true. It is radiology, and radiology, most importantly, that helps in staging and classifying disease that can help us treat. And it has to be done in consensus with our ENT and neurosurgery colleagues.
Okay.
So you do carry on your surgery up to the pterygopalatine fossa. It has to be go up to that
ENT
layer.
surgeon,
Then only you can
yes,
remove everything.
Because that has even a lot of patients that we've also seen after debridement of the sinuses
Right.
for a long time have recurrent disease that we see on MRI. And it is the ENT surgeon who suggested that we need to clear this reservoir of pterygopalatine
But the anterior
fossa.
part was okay. Do you remove the anterior part also?
No. So
Okay.
if
Only go
imaging there is no mucosal edema or involvement of the pterygopalatine fossa, then they leave it. Only in cases where they see it, even though the mucosa may be healthy, if on MRI it lights up, as in there is a contrast alteration, then the ENT prefers to be aggressive, especially in younger patients.
Did the ophthalmic management change depending upon the mucosa involvement?
So if we look at the classification system that has been proposed, it says that if the nasal mucosa is involved, the treatment is to observe or give systemic amphotericin B. No surgical involvement, no retrobulbar amphotericin B. Retrobulbar amphotericin B is indicated in stage 3B as per the proposed classification. So here we are seeing patients who had presentation would have been classified as disease stage 1 and been let go. So misstaging and understaging may occur if we don't treat every patient as an advanced disease, do an endoscopy, do an MRI and do a scraping on suspicion of mucormycosis.